Right, I can't lock the meeting if I'm not the host. So.
Okay, but you're an alternate host, so how do I make you the host?
If you go to participant, have you got a PIN number?
I might ask you to do this offline.
Yeah, I'll do it in the background.
If you can do it in the background, I wouldn't mind starting. So if I may, I'm going to start. Is that okay, Trudy, Katie? Yep.
Yeah.
So
yeah.
welcome everybody, and particularly to our online members of the public. I just wanted to say a little bit first. So first of all, a little bit about how we're going to manage this meeting. So as is always the case in our board meetings in public, it is a meeting in public and not a public meeting. And we are really welcoming of all of you that have actually dialed in to our WebEx today. We hope you find it worthwhile and interesting. This is the first time we've ever tried something like this, and we're really keen to restart our meetings in public at the earliest opportunity. You won't, as guests to the webinar or to the board meeting, be able to be in vision, but you will be able to see us and to hear us, but you won't be able to speak unless you were to have had a question that has been submitted in advance. So I appreciate this may feel a little bit rigid, but this is, as I said, the first time. We'll learn from this, and then we can develop this as the needs be with time, as time goes on. So welcome everybody. First of all, Erin, if I could just have any apologies for absence, please.
From Ian McBeath and Jill Ainsworth.
Lovely, thank you. Okay, and then any interests to declare, please, Erin?
I have no interest to declare for this meeting at all.
Okay, just as a reminder for those of you that are watching us, all of our interests, register of interests, which are regularly updated, are on our website under the section Managing Conflicts of Interest. Okay, so I'm going to go now straight on, if I may, to item 3, which is the minutes of the last meeting held in public on the 30th of January. So first of all, for accuracy, we have pages 1 and 2, pages 3 and 4, pages 5 and 6. So is everybody happy in terms of accuracy? Yeah, I'm getting lots of, we'll get a few nods of heads. Okay, thank you. Any matters arising or inaccuracies that need to be addressed? Okay, I'm going to take that as read. Okay, so now move on to the action tracker for those of you watching it online. It's in the pack. So the first one, which is development of the integrated care partnership. David, is there anything else you want to say on that? It's still an open item, obviously.
Yes, so we've held our first ICP board this week, Nicholas, and we're re-engaging with some of the activities in terms of developing our integrated care partnership. I think probably at the next board we'll be able to provide a more in-depth update on those developments. So we'll bring back a presentation for that board.
Thank you. Okay, so it will remain open. Next one is the BAF. Katie, anything that you want to add to that?
Hello, just to say that we did originally say that we would bring the BAF back to the May board, but in the light of the new guidance that had arrived about restoration and recovery, we decided it was more appropriate to spend some time making sure that we took all of that into account. So the board will see the plan for 2020-21 for the BAF will come to the June board meeting in private, and then we will take it to the public meeting in July once the board have had time to discuss and agree.
Thank you. Okay. Okay, moving on to the health and safety strategy and policy. Hein, is there anything else you want to add to that?
No, just that the majority, 95% of the staff have received their training. There are a couple that have not yet. So I think if the board's happy, we can close that off.
Thank Thank you. Okay, next one is the CEO report, which obviously, David, in terms of the UTC, David, do you want to add anything on that item?
No, so this was pre-COVID, and there was a view that the board members would like a tour around the UTC when it opens. I think that's probably unwise in the current situation, so we will defer that until times are more safer for that to take place.
Okay, and then the next two items that have Avni's name against them. Avni?
So with regards to the ERM, yes, that will be taken into account with further reporting so that the categories of A&E are well explained in any reports that we do, so that item can be closed. The next item is around adult community services. Again, that was pre-COVID. We are actually now moving into recovery restoration. So there will be further updates, part of recovery restoration on that one. We can close that.
So all of those both two will be handled, and we will have further discussions in public when we next meet. And then the final bit was the audit committee report. And Katie.
It's on the agenda as part of the annual report.
Lovely. Okay, so that remains open until we've discussed it. Okay.
Nicholas,
Yes.
sorry.
Paul, yes.
I mean, the specific actions around conflict of interest training. I mean, it is something we do need to make sure board members wrap up. I don't want to leave it till the audit committee report gets there. We need to be able to. We have to send in our regular declarations to NHS England, and one of the things that gives assurances that people have done their training. So we do need to absolutely wrap it up, and people do need to just get on and do the 15 or 20-minute module. But it's all it takes if you understand it. And if you don't understand it, then you need the training even more. So please, could board members do it?
Yeah. Okay. I wasn't aware that we had major gaps in that, Paul. But if we have, then this is a polite reminder to everybody to fill in their training. As Paul says, it's a very quick training if you've already done it before, but very important to make sure that that is completed and that we have 100% compliance. Okay. So next item is over to Urim. So were there any questions that were received from members of the public, Urim?
No, we've had no questions come in at this point.
Okay, thank you very much. Okay, so I'm going to move straight on to some of our strategic discussions, and this is an item that I think will be very broad in its coverage. I will clearly take the papers as read, but over to David, Diane, and Elka. So, David, are you going to kick off?
Yes, I will kick off. Thank you, Nicholas, and this will be an item that myself, Diane, and Elka will talk to. And it's the first time that we've had this conversation in public in terms of how we've managed COVID, how we've managed the incident, and how we are moving into recovery. So I wanted an opportunity to explore in public board the work that we've done, the structures that we have set up, and the ways in which we will be moving forward into the future. So within your papers, you have a set of slides. And really, it does take us back in the journey to the incident management arrangements that were set up on the 2nd of March 2020 as per Simon Stevens' declaration of a level 4 incident that took place. Within that space that we decided we need to reframe the clinical commissioning group and restructure it to a way in which could manage the incident, manage business as usual that was still being stood up, and support the system in responding to the pressures that were dictated to it within the COVID incident. So we tailored our leadership and delivery structures to meet that, and we had an IMT, and we were managed to put into place all of our emergency plan and response training that we'd have done years and years of in terms of setting those structures. So as you can see, the management of the incident involves responding to requests. Huge number of requests came in, whether they be diktats from the centre, changes to government policy, changes to procurement policy, and all of these had to be managed swiftly and quickly, and often on a 24-hour or even sometimes half a day's turnaround. To do that, we did have to change the way in which we operate as a CCG, and we also had to move quite swiftly into working from home arrangements, which this CCG had managed exceptionally well, and it's testament to the staff who've been able to deliver the services over the last 4 months in that manner. That's really, really helped us achieve some of the outcomes that we have. We always had this well planned out in terms of IT because we could only be 60% occupancy within the CCG, and I think this has meant that we've been an agile organisation during these COVID times. We have had to redeploy staff outside of the CCG, and again, a big thank you to all of our staff who have put their hands up and worked within the hot hubs and worked within other organisations to provide additional care. And that goes across the spectrum from people in our CHC teams and nurses, all the way through to administrative staff who have gone out of their way to support some of the endeavours that we've had to face. So we've managed to sustain our kind of connectivity within the organisation, and you'll all know that we've had staff webinars, and we've done that twice a week so that we can connect as an exec team with our staff, and I think that's been fundamental to ensuring that our agile and mobile virtual working has succeeded. And I think that's just, I guess, a demonstration of how we've been able to adapt in these times. So I think in reality, these are the kind of big structural changes that have had to take place over that period of time. I will hand over to Di at the end of this to talk about some of the detailed work and instant challenges that we face currently and have done. But during that process, and all of our training through EPRR, which is Emergency Planning Response, has always been around manage your recovery as quickly as you can while you're managing your incidents. And best practice says that you need to be looking at both, because if you haven't got your eye to recovery, you can't work your way out to where you need to be. And recovery in this instance means a combination of things, whether it be a collecting of a Diane silver linings that are the best practice that we've been able to forge out of responding to this process, and some of that would be around virtualised care, different ways of operating, to trying to actually rethink opportunities to set up new structures and new ways of operating with partners that we never had before. So on the 29th of April, Secretary of State wrote to the CCG accountable officers and signalled the start of the phase 2. And so phase 2 was really about looking into that space. We've managed to peak. We were coming down in terms of numbers of people going into hospital. The death rate was slowly declining, and we needed to think about how we would manage and continue to support. At that time, we also needed to work with local authorities around care homes and how we might manage some of those pressures as well, and those partnerships retained and remained strong throughout this process. So if I take you to the first slide where there's a structure chart, you'll be able to see, which is page 18 in my pack, you'll be able to see a structure in terms of how we've responded and how our instant control centre that was set up, which has been manned 7 days a week and been fundamental to our response, has really driven through into how we manage the strategic, the tactical and the operational. And this describes how we have managed those two, and we now instigated our new group, which is around recovery. So Diane has been our exec lead for incident management throughout, has done a fantastic job in managing the teams and work within that. Avni Shah has been managing our tactical delivery groups, and again, making sure that all of our services are up and running, and the commissioning function still takes place. And we have had Lynn Dalton doing the work around primary care and sustaining primary care and the pressures that have been managed within there. We've had Hein looking at the workforce, the well-being of the workforce and the mental health. And we've had Alka looking at the finance and how we maintain our COVID spend against our statutory spend and our statutory responsibilities. And you'll see, fundamentally hard work has gone into the annual review. And we've got Juliet Rogers as well, who's been doing 7 days a week communications, because this is a job that doesn't end, and the news has been particularly hot in this space. And to wrap it all up, Katie, within our governance as part of the exec, has kept us tight to make sure that we've worked within our fundamental constructs of how we make decisions within the CCG, and has been great check and challenge on this front. So if I take you to the next slide, this is the one that starts with we are also updating our governance arrangements. This really does describe the CCG in a wider context to the world. It looks at the COVID incident management and the restoration and recovery, and how NHS England and NHS Improvements, alongside our committees and the boards, are taking accountability and responding. We felt that recovery was an executive function because it just spans across the breadth of the organisation, and that will be led by myself as accountable officer, and will continue to be led as managing director, and Diane will continue doing the work around incident management with a view that that has reduced in terms of its pressure and will move back into some of her more traditional role as Director of Nursing. But in reality, these will continue to be part of our governance framework, at least probably till March 2021, where we will need to then decide how we set our structures up. And if there's a second peak, we're having to balance the pressure on recovery and the ability to move back into what will be an incident management process. So if I take you to the next slide, this is around the COVID incident management work and how the collective partnerships work across the wider system. And for these two slides, what I'll do is I will move over to Diane, who will give you an update on the detail that sits within this process and can describe some of those incident areas that we've been focusing on. So can I hand over to you now, Di? Does that feel the right slide?
Okay, thank you. So, as David said, we are maintaining the incident management function that you are well cited on. And as you know, we've been providing weekly updates to the board on the work of the incident management team. And the work that we're doing now, as David's described, as the governance needed to change to focus on recovery, is around what do we hold within a COVID incident management function, and what do we move into a recovery phase and recovery cell. And some of those work streams will straddle both of those. And so, you know, that this has been quite a complicated sort of governance piece of work to get to a good place in terms of moving into the recovery phase. So the wider work across the system and across the region has been for us to stay closely connected with other partners. So you can see on the slide 20, the COVID incident management, that we've also worked alongside the strategic coordinating group, which is an emergency planning response to incidents, and is actually chaired by a member of the fire brigade, but has representatives across all public services. So it's been a predominantly health incident for us, but actually it goes way beyond that, and particularly in terms of recovery, it goes way beyond that around the local authority and the local council responsibilities. So we're very engaged with those as well. We've also run throughout this period a tactical delivery group. So we've had a West Hertfordshire tactical delivery group, which has brought all of our providers together to really talk about what are the key issues across West Hertfordshire, and also to build in elements of mutual aid. So there's been a real coming together of our community and acute providers to work collaboratively. So as David said earlier, I talk about the log of silver linings. I think there's been some amazing work in terms of how we work collaboratively across the system, which, you know, we will hang on to and build upon. We've also had a Hertfordshire-wide tactical delivery group for health, which has meant that we can widen that mutual aid and support. So we've seen where issues with personal protective equipment have happened in West Herts Hospital, we've been able to facilitate East and North Herts Hospital supporting that, and we've been able to share good practice and learning across the system. So again, you know, some really positive stuff around how we've worked together as we move towards being much more closely connected with our STP and partners across East and North Herts, and also into West Essex. We've also had to be very engaged with the NHS England assurance processes. So in terms of the incident management, we've taken instruction via the East of England region of NHS England about next steps. But we've also been part of their system call 3 times a week and providing regular assurance to NHS England through that process and development of slides 3 times a week, which gave us also an opportunity to raise top concerns and get answers very, very quickly. So it's actually been a very impressive process of keeping everybody informed and all heading in the right direction. On to the next slide, in terms of the operational management approach, as David said, Avni has led the tactical delivery group brilliantly, which basically pulled the entire CCG together into a delivery group to operationalise everything we needed to do in relation to COVID. For a long time, he referred to them as the team upstairs, even beyond going virtual, because it fundamentally was a real conversion of the CCG teams to react to the requirements. So you can see on slide 21 a list of some of the key work streams that we had running within the incident management process. As I said earlier, and David was talking about the governance, what we've started to do now is work out which of those need to go into recovery. So some of those you will recognise as our work streams normally, so the cancer and the acute and community care, children's and young people's care, obviously we'll move into the recovery phase now to see how do we step that up. But what we do need to do is to maintain that incident management approach to manage those things that are beyond our normal business as usual. And the key ones are probably the first 5 on that list. So the respiratory hubs and the cold hubs were approaches we took, particularly the respiratory hubs, approaches we took to ease some of the pressure on the acute services and to support GPs to be able to deliver normal general practice in amongst delivering what needed to be done for people with COVID-like symptoms. So Daniel did a fantastic job of being the clinical lead and really driving this at pace, and we were definitely well ahead of the curve with putting these in place. So we currently have a respiratory hub in each locality of the CCG area, which sees people with COVID-like symptoms and can assess and refer on if appropriate, but in the main manage people in the community safely run by our GPs through the federations. We've also having to maintain a very strong focus on personal protective equipment, or PPE. As you know, from the news, it's been a real challenge, and we have reached some very difficult times with PPE across the system, but actually have never been in a position where we haven't had PPE available to staff that meets the guidance. The flows and the supplies of that are improving now, but it will maintain, it will have to be retained as a work stream that we will continue to monitor through the IMT. Particularly, it will need to straddle the recovery work as well, because it's absolutely crucial that you have the right PPE to protect the staff when you bring people back into the NHS. And to make sure that you are preventing nosocomial infection or cross-infection within the hospital from staff to staff, patient to staff, and patient to patient. So it will continue to be part of our way of working for probably a very long time to come. The other area that's been a significant focus for us and has actually become a bit of an industry, I think, is testing. So we have responded each time the government has ramped up testing for staff and the wider public and care homes. We have had a dedicated team working on that piece of work to make sure that we are implementing everything that is required. And we've had mobile testing units and static testing within our provider, CLCH, to ensure that we were able to meet that. And we've also had our care home improvement team supporting the care home swabbing out in the community. Again, testing isn't going away. We're now working towards the antibody testing being implemented this week. At the moment, we're working through laboratory capacity to be available to do that. So that's all being validated at the moment, and we're waiting for NHS England to approve the stand-up of antibody testing for NHS frontline staff. Just to reiterate, that is, antibody testing will tell people whether they have had coronavirus, COVID-19. It won't at the moment. We have no science behind it that will show that they have any immunity, but we hope that that will start to come through very soon. There's a lot of testing going on through public health around what will this demonstrate immunity. The other element of testing is that this week the government are launching the test and trace process, which is going to be led by public health staff. So 25,000 additional staff have been trained in this across working with Public Health England across the country, and they will lead that initial contact tracing. And on the back of that, probably I think it's from the first week of June, we will start to see the app being used that will support that contact tracing. But the bedrock of contact tracing has to be public health before the app is brought on, which you will know was tested in the Isle of Wight, and some very positive feedback from that. So testing isn't going away, and we are working on what does that team need to look like to keep that going. And I think that's, you know, that's going to run for the foreseeable future. The other area that I just wanted to mention that has been a significant focus has been care homes, and obviously that's been a huge amount of work for us within Hertfordshire. In Leafy Green, Hertfordshire, we have lots of care homes. We have a total of 146 care homes that we're working with. So that's residential and nursing and all age, so learning disabilities, children's and older people. And we've been doing an awful lot of work. I think it's fair to say we started on a strong footing, because as you know, we've always had our care home improvement team. We've always focused on admission avoidance and ensuring that our care homes are well supported and trained, but obviously we've had to build on that as this work has gone on, and we're now just about to finish this week training all care homes in the national COVID infection control training, which has been a huge feat and a great achievement over just 2.5 weeks. We have achieved that, and obviously supporting them with training as well. Some of the other areas that will stay with an IMT focus are around the homelessness and the voluntary and community sector, which we're working very closely, obviously, with the local authority, and also the vulnerable and shielded patients, which we are strongly engaged with the local authority as well around how do you support those people to remain in their homes and protected. Just in terms of a little bit about staffing, as David said, we've redeployed a lot of our staff out to the hubs and out to HUC to support the 111 work, and we are starting to see them come back, because that was a temporary measure to allow others to put processes in place, and the HUC 111 activity has come down significantly as well. We're putting in a lot of support for health and wellbeing for our staff in the CCG, but also working very closely with HPFT to support staff across the entire system. And I think it's fair to say that it will be a real enabler, or something we have to really consider as we start to ramp up services, that we've got an exhausted workforce across the NHS. From the intensive period that they've been through. There's lots of measures which I won't go into detail at the moment, but obviously, a lot of support. Also a lot of work on risk assessment of staff in relation to whether they are vulnerable or they live with someone vulnerable, but also the BAME risk assessments, because we have seen that is a significant risk factor in terms of COVID. So take a deep breath there and leave it there, and pass back to you, David.
Thank you, Di. So if we move to slide 23, where we start to look at timelines of recovery and restoration. I think one of the key messages that we had throughout this process was when will the NHS be open for business? When can I go back and get my planned care or my elective care? And how can I ensure that my needs are met that weren't around COVID issues, but were issues that might be building up, and that's around mental health, physical health. And so part of the restoration and recovery plans was to help to get back in line some of the services that were stepped down pre-incident to manage the incident. So now we're having conversations and we're looking at some of those silver linings, seeing where we can make benefit of new ways of working and new best practice, where we can deliver virtualised care. There is a pressure on this for timelines to be instigated, and on this one, you can see what a timeline that works for September, which I think is ambitious. I think the reality of how much we've restructured the NHS will come clear in the next few months, and how we manage what are now being called green and blue sites, with green being accessible to people who are COVID negative and blue sites that are accessible to people who are going to be COVID positive, and how that will be managed in the future, which will take quite a structural change. So the task of restoration, recovery, the language that we need to use is significant. And it straddles across multiple areas as well. So we will be recovering as an integrated care system. We'll be recovering as an integrated care partnership, and organisations that sit within that, which will be your Herts Partnership Foundation Trust, which will be West Herts Hospital Trust, which will be Herts Community Trust, CCG, and a collection of other providers will need to restore and recover themselves from the instance. And it's really important that we do this in partnership with one another, and we're able to make sure that we benefit from the collective opportunities that creates for us. So we have, although I've demonstrated to you and shown you the structure chart for the CCG governance, there will be a wider set of conversations that need to take place to enable that to happen. So if we go to slide 24, you can see the areas of focus that we think as a CCG need to be expedited and focused on. And these are the urgent care, planned care. I won't read them all out, but they're a selection of areas that we think are ways in which we need to get back to business and improve some of our thinking. And it will also include areas that you wouldn't necessarily see as delivery points of care, but areas such as finance, contracting, business intelligence, as our contracting regime and our financial standings have changed. And Alka will talk a little bit about that after I've completed my final set of slides. So you can see there's information on the recovery plans within slide 24, and 25 demonstrates some of those links. We've now got in place a twice-a-week recovery management team meeting with recovery management groups that sit underneath that. So there's a lot of work that's happening, and as Di said, some of this is shifting some of that activity from what was in the incident management work into now recovery work, and we're trying to ensure that we've got the connection with the right members of staff, and that we can flick from one mode to the other if we have another spike, which would be planned around, at the moment from the data, October time or November, with a third spike being planned for March time. So we just need to make sure that we're geared up within the organisation and within the system to manage that. The good thing is that there is lots of focus on recovery at the moment, lots of people to work with within the system, and to take some of those good best practice models that we can work on. We may look very different at the end of this as a system and way in which we deliver care, and that will be potentially the opportunities that present themselves to us while we do this work. So at the end of my bit, I'm going to hand over to Alka just to give the board and the public a sense of what the financial structures that may have changed while we're in this process that have changed the way the CCG is operated. So Alka, can I hand over to you briefly?
Yes, thank you. So just a very brief update to board on the financial arrangements, and I'll sort of go back to March when COVID became a real issue, which was our standard time for operational financial planning and agreeing contracts with providers for 2021. So the very point that we had almost completed that process, all of this was stood down and replaced with other other ways of work and other ways of managing our finances. And really, the main change probably for board to be aware of is that NHS England have taken on some of the direct contracting responsibilities with acute providers, including independent sector providers, in order to be able to manage capacity directly and ensure that cash flows appropriately and doesn't become a hindrance to the way that we work. So we don't contract in a way that we did in 1920. The burden of that kind of contracting arrangement has largely been stood down. What some of our back office staff are doing is then supporting some of the incident management as well as recovery planning with business intelligence information. So we've been able to be direct resource in that area. It's probably also worth bearing in mind, even though it feels like COVID has been around for an awfully long time, this is actually, we're only just entering the financial reporting period for 2021. So we will, as usual, produce our financial reports to board. They will look slightly different because they will reflect the regime that we are now working to, which has ceded some of the control to NHS England. So we'll be reporting simply our expenditure in line with what NHS England have given us as a budget. But normal financial processes will resume, are in train, and there hasn't been a gap. It's just been a normal passage of time from one financial year to another. So come July, we will do our first reporting for 2021, and that will include a report on our COVID expenditure, which we have been able to claim back from national funding. And we will include some detail on some of the schemes that we have been funding to ensure we have an appropriate response in managing the COVID crisis. This is a very much a changing landscape. At the moment, we're working to a financial regime that is for the period to the end of July. And I'm sure we will hear more very soon about how that will look as part of recovery, how that may change, or whether it continues in this way until later in the year. That's probably all I wanted to brief the board on now. That we will be reporting formally our finances to the next committee as we ordinarily would at this time of the year.
Okay, thank you. I mean, I think I just want to kick off this item really by just reflecting on just the enormity of what the incident and all areas of the CCG have had to concentrate on during this time. And I think this paper describes that very, very well. I think there's no sector of our providers that have not been truly affected by this, both from the acute trust through to mental health and community providers, and also primary care, which have actually had to adapt enormously to very many challenges over the last few months. But I would like to record, Diane, the appreciation certainly of myself, but I'm sure on behalf of the board, of all the hard work and leadership that your team have shown during this, as also to David in his work. But now I'm opening it up to the board. Yeah, Stuart.
Diane, and can I just replicate Nicholas's thanks, and also to David. It's difficult to mention names because it's been such a huge team effort, but my thanks to everyone who's rolled their sleeves up and just got on with it. I just want to refer back to slide 24, if I can. The areas of focus going forward. There are 7 areas there, all which are vital and important. But I suppose from the public's point of view, it's obviously the waiting list issue and how we recover from that, but also particularly for primary care. I'm assuming, and things we've been discussing over the weeks, primary care will look very different going forward. I know it's difficult now when we're in a hot, sunny spell to think about the winter months and flu jabs and all of that, but we are having to start preparing for that, no doubt. So just a quick overview, perhaps from Lynn, on how primary care will be dealing with patients in the future, just to give a quick flavour of that, because I'm sure the public is anxious to find out how that's operating going forward.
Thank you, Stuart. So primary care has been exceptional during COVID. They have moved forward substantially. We were in a position where we were actually able to implement video consultations literally within 72 hours. So patients can still access their GP through telephone triage, telephone consultations, video consultations. And practices have kept their doors open. So once patients are assessed that they do need to be seen, they've been brought into the practice and seen. So they've responded extremely well. They're keeping their websites updated. They're notifying their patients. They've also, we recognise that moving forward, these changes will probably be here to stay for the future, because they were plans that we already had in place. We're also in the process of finalising a procurement for e-consultations, so patients will be able to consult their GPs electronically. So we've got a journey to go on with primary care. They've worked incredibly hard. They've been very responsive to ensure we maintain patient care, and we've got work to do to start to plan and prepare for the winter months. And you're quite right, the flu campaign is going to look very different this year, and primary care will be part of a system approach for delivering the flu vaccine programme this year, as understand it from NHS England. And as part of our recovery and restoration programme, we're looking at actually how can we really benefit from the changes that we've put in place, so that patients feel fully supported, and also that we're in a position, should there be future peaks, that we can manage primary care. But as they've been excellent in terms of being a system player as well. If we think about primary care, as Diane said, Daniel led the development of the respiratory hubs. That's enabled us to take primary care into the respiratory hubs to make sure that those patients were looked after properly, and GPs and nurses, reception staff signed up to work in those hubs. It's been a really good approach that we've received over the last few months.
Thank you.
Rami, sorry, I was on mute. Okay.
What I really would like to get some assurance is, what roadmap have we got now back to getting some of the new normal in place, so that our non-COVID patients can get assurance that care is available, care is accessible, and that there is a way of providing that care?
So that's a good question, Rambi. So you're aware of the Simon Stevens letter around the work that's been done nationally on care homes. We're expecting a new enhanced service to come out nationally in October as what's considered best practice. We've already reviewed what we provided pre-COVID and currently do for all our care homes, and we've worked that through, and we've realised that the one thing we really need to do is put in place for our care homes is weekly virtual multidisciplinary team meetings of every home, not just care homes, but learning disability, mental health homes, and we're actively working on that and ready to implement that within the next 7 to 10 days. So that's a real progress going forward. As you're aware, we're looking currently at a programme for patients that have been identified nationally as shielded. So how can we make sure that they're maintained at home? How can we support them? And we're doing that work to support practices, because actually it's about, can practices go out and visit them? Do they have the resource to do that? Because actually you can see maybe 10 patients in a short period in a practice, but once you start doing home visits to see those patients, and then you're starting to don and doff your PPE, that takes longer. So there is another work programme going on to look at that. I think in primary care we've been exceptionally lucky in a way, because whilst the schools have been closed, the community nursing service has supported the practices, and they've been providing the childhood immunisation clinics, and that's been quite vital for us, because obviously what we didn't want to happen is during the COVID outbreak is had the childhood immunisation levels drop. So that's been beneficial. That seems to be well received by practices, and we will work with school health to see actually is there any more flexibility for using those staff to support practices over the winter. So we've still got work to do, but it's all part of our recovery and restoration programme.
Okay, I think Asif has his hand up. Yeah, sorry.
Thank you. We know many practices in our area doing a lot of work supporting vulnerable patients, like patient in the learning disability group, children in child protection list, dementia patients who are traditionally very find it very difficult to contact practices, so proactively contacting them. Would CCG sort of push that idea, support the practices, and share the good examples to the rest of the practices so we can all support those vulnerable patients?
Absolutely, Asif. I think that's one of our key priorities. And as we've said, supporting the LD homes and the mental health homes with the weekly virtual check-ins. And we're doing that with our community provider, CLCH, and also all our learning disability nurses. So the whole programme about what did we learn in COVID. You know, we feel we were delivering good primary care. We've changed to adapt to COVID, but actually how do we take forward the learning and make sure we embed that as best practice? And that's one of the key outcomes for us on the recovery and restoration.
Okay, I'm looking for any other hands. I'm not seeing. Oh, Alison, sorry. Yeah, you're on mute, Alison.
Apologies. I just wondered if we could expand slightly on the previous points and reflect on the other kind of inequalities that emerge in the way that this virus impacts. And I'm aware there's an awful lot of information that seems to be seeping out about the impact on the AME people, and I'm thinking there of both our staff and patients. And I'd be interested to know what we are doing to kind of maintain and fulfill our constitutional responsibilities in terms of dealing with health inequalities. There's quite a lot of this virus seems to affect people in a very unequal way, and I'm just wondering what we're doing about that.
So it might be a mixed answer from a few colleagues. We have data that comes in on a regular basis, Alison, that informs us from public health and from other areas about the effect it's having on different individuals. And we need to know that different individuals are exposed in different ways as well. So depending on what the workforce makeup is within a hospital can impact on the level of individuals who will be affected, and those in the community around their health and well-being. And there's been some papers that have been published recently around diabetes type 2 and the impact that that might have on your outcomes around COVID as well. So I think at the moment the collection of the information is what we're working with. We do know that there are shielded patients that we've had to look after within learning disabilities, and we've worked closely with Simon Patterson and the Integrated Care Commissioning team to ensure that they're managed, as well as the County Council in terms of their healthcare needs. So where we know there's specific focus of vulnerability, we've been able to target it. In the broader sense, I think we're still working out where the best impact will be, depending on usually either staffing or individuals, and what the best information that we can put out through public health support to individuals and their lifestyles as well. So there's a combination there, but other colleagues might want to jump in, because I know there's quite strong views as well in this space. Richard, you had your hand up.
Yeah, in answer to the question about what we've been doing, just to give an example on a small scale and then a larger scale from a well-being perspective. In our practice, we've carried out risk assessments using a validated scoring tool for all our staff, doctors, nurses, members of the admin team alike. And that has helped us to decide whether, for example, people should still be working from home, or whether it would be safe for them to come into the surgery. And we've just been having a conversation about that this morning. So we're very careful about that. And certainly when I speak to patients, even though they might not necessarily have been advised to shield, we know, as has been referred to, that there are quite different risks in different groups. There's an excellent paper called Open Safely, which is authored by many people, including Ben Goldacre, a well-known doctor who works at the Oxford Centre for Evidence-Based Medicine. And I won't go through the numbers, but essentially there are lots of multiple risk factors for increased likelihood of dying from COVID, including age, gender, ethnicity, obesity, hypertension, heart disease, diabetes, poorly controlled asthma. So we're using what we know about that in our practice to try and advise people on that. I've done a wellbeing update for the Royal College of GPs, and one of the things that the wellbeing team that I lead within the CCG, who perhaps haven't been as at the fore up until now, because it was perhaps more about urgent care and hot hubs. We're looking at how we support both our patients and our practitioners, and we'll be doing webinars and putting information out there in the public domain as well.
Okay, thank you, Richard. Diane.
Hi, so I just wanted to update a little bit as well. So I mentioned in my update around the risk assessments for staff around the AME, and that's been an absolute requirement across all providers, so our acute trusts. We've also done it internally within the CCG. But in addition, I think it's important to say, you know, we held on to business as usual where it was vital. And one of those elements was quality impact assessments and equality impact assessments. So, you know, despite the fact I was off doing COVID, I still had a team doing quality, and Paul Curry has been very active in all of the work that we've been doing. So, for example, we did equality impact assessments around the respiratory hub. So every time we've made a decision as part of COVID, we have assessed the quality impact and the equality impact of every decision, despite being outside of our normal processes. So hopefully that gives you some assurance, Alison, that it has been built into decision making.
That is really good. Thank you to all of you who, I just have one final tiny, the carers, I know we have carers on our agenda and their particular needs, but I just, there's one group that keeps bothering me, and it's child carers. Can somebody offer me kind of some assurance about what is happening to keep a particular focus on children in that position at the moment?
Shall I start?
Yes, please.
So in terms of the management of the staffing across the whole system, the Director of Public Health has had clear instruction that he is responsible for developing, obviously with the system, a local outbreak plan, and those sorts of elements need to be built into there around schools and you know, the wider services that we run in tandem with health, because as I said earlier, you know, this is a health level 4 incident as declared, but actually it touches so many other elements, that particularly in this phase where you start to stand up society again. So there are going to be specific local management plans for all breadth of carers and workers across social care and health.
Thank you all. That does provide a lot more assurance. Thank you.
Okay, I just wondered if we might reflect a little bit, Diane or others, on the intensity, the cases that we dealt with in the early sort of weeks of the COVID outbreak. I mean, one of the things that perhaps doesn't always come out in Hertfordshire or STP figures is the level of need that we had early on in terms of how it affected the acute trust and how it affected general practice. And I just wondered if there were any reflections on that.
Sorry, Nicholas, the beginning of your question broke up. I'm thinking I would answer it, but I couldn't hear most of it.
Okay, I'll I think, can you hear me now, hopefully? So it was really about the fact that the level of COVID in our population at the early stages, particularly of the pandemic, was very high as it moved in from northwest and north central London. And I just wanted to make sure that we recorded that, I suppose, in our minutes, because it is something which we had to adapt. Probably we had the most cases, certainly in the early stages, across the whole of east of England. I just wondered what your reflections was on that.
Yeah, I think, Nicholas, we've spoken about this before, haven't we? It was clearly a much more significant impact in West Herts than was seen across the rest of Hertfordshire. And actually, what was really helpful was the cross Hertfordshire working that we have been doing, which has enabled that mutual aid. So even down to sort of mortuary capacity and those sorts of elements, it's been important to work across as a system. I mean, I have talked previously about the London effect. I think, you know, when you think about that part of our patch being very close to London, and you will have all seen the slides of the enormous peak that London saw, and so the close proximity, I think, is what affected us so much in West Herts. Every single day we were monitoring those numbers of people in general beds and in ITU beds, and understanding what that picture looked like. And at no point did we tip over the capacity that was available. You'll remember quite a few weeks ago now, we had an issue with the oxygen capacity, but that was about being able to expand to allow more ITU beds, and we never got to the point where we didn't have enough ITU beds. But I think it's really important that we consider that impact of West Herts high numbers as we do recovery, because I think they have a particularly strained, you know, a workforce that have been troubled by this and have worked excessive hours to manage this. So I think it is really important that we do note the high number of cases in West Herts, as you say.
Okay. Any other points that the board want to make? I'm looking for any raised hands. I think the final bit I just wanted to mention was, you know, just to record on record in our public meeting the fantastic work and leadership of Daniel, our federation chairs, and also Diane, your team in infection control, in setting up the hot hubs for patients to be seen with suspected COVID symptoms, because this has had a major impact on reducing some of the pressures on our acute trust of patients turning up who maybe we were able to deal with in primary care. So I don't know, Daniel, if you've got any final reflections before we finish this item.
Thank you, Nicholas. I mean, I think the hubs have really helped drive sort of innovation as well, and perhaps giving us a glimmer of what the future of general practice look like. Because I think underlying the model was very much a sort of virtual care model, and we've even got the ability to get oxygen saturation monitors delivered to people's houses, so that the GPs can actually do better enhanced care. And I think that, to me, is a real glimmer of the future. It also has been, you know, tremendous work from the teams in the CCG, the federations, and everybody else involved to get, has felt like several years of work realised in about 3 weeks. So I really commend everybody involved. Okay,
Trevor, did you want to come in?
Yeah, I think just sort of finishing off, really, I suppose. Reiterate the points, and I think the whole team has done very well in terms of, you know, responding to a rapidly changing and huge agenda. You know, we've heard some of the things that we've managed to do. So, as David mentioned, the next stage is, you know, the recovery phase, and as Daniel's just alluded to, I think there's a lot there that it's not just a matter of getting back to normal, but it's a matter of you know, trying to improve things for the future, for patients, efficiency in general practice, efficiency in acute hospital. And that's our next challenge, and that we're working on that. So obviously, you know, we have been hit in our area maybe more than other areas in terms of COVID, and therefore the acute hospitals had to respond in a certain way. And now we're trying to get things back so that we can provide, you know, safe and effective care to patients, and bring that all back into the mainstream. So, you know, there are lots of streams of work. You know, there's work in general practice too. I mean, the use of virtual consultations has come on immensely in 3 months, which probably would have taken 5 years. And so we want to build on that. In secondary care, you know, there are challenges because no routine work was done for 3 or 4 months. So we have to, there are 3 streams of work on that, and that's sort of working out all the cancelled appointments and making sure the patients who had appointments cancelled have those reviewed and a plan come up for them. There's those that have been held by general practice, not referring in because, you know, obviously the hospitals had other priorities. Those need to be reviewed and you know, sorted out. And then the opportunity for change is sort of new systems so that things can be more efficient for patients, for hospital, for general practice. Examples being, you know, possibly in the future, first outpatient appointments, if possible, being virtual, so which will improve, you know, reduce patients needing to travel, reduce car parking issues, reduce estate issues at the hospitals. And these are all actually quite exciting things for the future that I think we can build on this, you know, this unfortunate pandemic, and we might come out of a bit like a phoenix out of the ashes. I suppose that it's been a bit of a problem, but I think it could actually strengthen our position in the future.
Richard, sorry.
Whilst I share Trevor's optimism and won't repeat all the comments he's just made, I think we do also need to bear in mind that we're facing a lot of uncertainty. And when people ask us the question, when will you be back to business as usual? Well, the first part, as Trevor answered, is that there won't be any business as usual. The future will look different. But the second part is it very much depends on external circumstances. Even the most optimistic estimates of what will happen with the R number of COVID as we relax lockdown, even taking into account the slowest and least aggressive relaxations, we see that R number rising to above 1 and even above 2 in the next few months. And we need to just bear in mind, you know, depending on the behaviour of the public, and I include myself as a member of the public, in the nightmare scenario is that we have a second spike that's worse than the first and we have to go back into total lockdown. Business will not be continuing as usual and we will end up in a very similar situation or worse to how we were when this all started off. The nightmare scenario of having to make decisions about who gets a ventilator didn't occur, but that's not to say that it couldn't. So I think when we have these discussions with the public and with our hospital trust as well, and with general practices, we need to bear in mind that we're not out of the woods yet. And so whatever we plan going forward, we have to be quite light of foot and we have to be able to fall back on all the hard work that we've done so far, including specifically the very good example of the hot hub, which may not be as busy now, but could become so again as we get down the line in the next few months.
Final, Elka, or Diane, is there anything else you wish to add before we actually finish this discussion? I'm not getting any burning.
No, I think
Diane,
Richard
sorry.
is absolutely right. I think Richard is absolutely right to caution on that, and that's exactly why the governance has been set up with instant management continuing alongside recovery. And we talked about, should I be on the recovery? And I said no. Actually, what I need to be doing is challenging recovery based on what we're seeing in the modelling and the instant management as that goes along. So, you know, I guess the assurance to the board is that we're not taking our eye off the pandemic whilst the recovery is going on, and that's why it's such a challenging phase. And although the first phase was exhausting, I think this is technically and you know, trickier to deliver. But it's absolutely right at the front of all of our discussions.
Okay, thank you, Diane.
Nicholas,
Yeah,
Nicholas,
David. Rami, then David. Yeah, then we close.
Can I
Yeah.
just add that we need to also be mindful of the amazing input we've had from Health Education England, from all the juniors, both in medical juniors, the new entrances from the medical schools, the nurses that have come in at the beginning of their career quite quickly. These are all people who've been the backbone of us dealing with the first spike of the pandemic, and we need to actually support them and make sure that they are trained and mentored appropriately at the beginning of their careers, that it is not just taken for granted.
So I think here for that. I think David, final say. Yeah.
Thanks, Nicholas. I think on my reflections and the conversation, I don't think we've ever lived in a time where risk and opportunity are so lightly balanced. You know, that it will move between one or the other. And there will constantly be risk and constantly be opportunity. And I think what we've tried to do as an exec with the structures that we've created is to manage that into the future that will sustain it for the next rest of this year, so that we can manage exploit the opportunities that come out, but always be aware of the risks and flip our organisation into the right response at the right time. But it is times that we've never had in this respect, and I think we need to always be sighted on both of those elements. So that's really kind of what I'm hearing, and I think this is how we want to push the direction of travel of the organisation for the next year.
Okay, David, I think that's a really good way to summarise and to finish this item. So thank you very much, everybody. Welcome, Ed. I think it's just returned from another meeting that you were chairing. So, Ed, I'm going to ask you to introduce the next paper, item 7, section 75, deed of variation. I'll take the paper as.
Great. Thanks, Nicholas. Can I just check that I'm broadcasting? Can everyone hear me? Great, thank you. Morning, everyone. Good to see you all. This presents board with a deed of variation. The deed of variation makes changes to the existing Section 75 agreement that exists between Herts Valley CCG, East North Herts CCG, Cambridge and Peterborough CCG, and Herts County Council. Board members will recall the Section 75 agreement is a legal partnership framework through which we undertake areas of joint work and joint commissioning, most notably the Better Care Fund and the joint commissioning of mental health services. This deed of variation is proposed to board to ensure we've got the appropriate agreement in place to cover elements of our response to the pandemic, and specifically the COVID-19 hospital discharge service requirements, which the government mandated all local systems to put in place as of March 19th. Section 2.3 of this report summarises the key elements of those mandated requirements, which include the temporary suspension of CHC assessments and the commitment that the NHS will fully fund additional elements of out-of-hospital health and social care support for an indefinite period. Actually, there's no until they say they won't, I think is where how it's worded really. So a county-wide out-of-hospital group and discharge cells on both the east and the west have been set up and have developed these services to increase capacity and respond to these requirements. So this deed of variation therefore introduces an additional schedule into the overall Section 75, which sets out the aims of the hospital discharge scheme. It confirms there's no formal delegation of functions required between any of the organisations that are part of that Section 75 agreement. It sets out the commissioning, contracting, monitoring, risk share arrangements, and the governance arrangements. In terms of governance, this will all be monitored by the existing HCC, Herts Valley's Strategic Partnership Board, which is the body that's already responsible for making sure that the Section 75 is doing what it's supposed to do. There are no specific equalities or quality implications of this particular recommendation or of this particular legal change, although we'd obviously expect respective organisations and respective commissioning teams to be doing the due equalities and quality work around any services they're bringing on board as a consequence. In terms of financial imps, I will turn to Elka. I know the front sheet went out without the resource implications, so Katie's just asked me to read out the fact that expenditure captured by this agreement is reimbursable from the National Discharge Flow Funding. But Elka, I didn't know if you wanted to come in on the specifics around the finances.
Yeah, I'm happy to. So this variation really just captures the funding flows around the 1.3 billion discharge funding that has been made available nationally. So hence we can't state what the contributions are to the pool, which we normally do, because it's based on expenditure. So you know, whilst the acute discharge flow teams apply, this will be operated through the pool. Herts Valley CCG are the payer of monies on behalf of Hertfordshire. So all of the funding that flows to Hertfordshire, we will pay to Hertfordshire County Council on behalf of both CCGs. That was one of the requirements in the guidance, that we would have both a lead commissioner, which is the council, and a lead CCG through whom the funding flows. And that's the arrangement we have put in place.
So thank you, Elka. So that was really a quick summary of the report, Chair. I don't know if there's any further questions that board members may have.
Thank you, Ed. Yeah. Questions, please. I'm not getting any takers. I think it was very clear. I mean, the paper's very clear, Ed, and your explanation is very clear. So we're being asked to make formal approval. That's correct, Ed, isn't it? Yeah. So do I have the board's approval? Yep. Lots of nods of head. Thank you very much. Okay, that's carried. Thank you very much, Ed. Now over to thank you. Now over to the next item, item 8, which is the West Herts Hospital Trust Estates verbal update, which is David and Juliet.
Thank you, Nicholas. I'll start off and hand over to Juliet. This really is, I guess, demonstrating that work is continuing in some elements of the health service outside of the COVID incident that we're currently experiencing. And West Herts Hospital Trust have continued to develop the work and the plans that were previously agreed by this board in the strategic outline case that was signed off last year. So as you will be aware, the build-up back around January time was that there were conversations with the Prime Minister's office around the amount of money available, about the capital requirements to improve the build based on the agreement of the stock. And they had continued with assurance at the time that funding would be available, although we had not received anything in writing. So with that in mind, we were asked by NHS England as a system to continue to work on those plans, and West Herts Hospital Trust have had a part of their organisation that have continued to focus on this, because they felt that actually, and I probably agree, that during this time it's important that we look to what we need in the future using some of the experiences that we've currently had and reconfiguration and transformation that will take place over the next period of time. So ongoing dialogue has continued with the regulators regarding funding. They're expecting a recommendation from the Capital Development Committee and Joint Investment Committees at the beginning of June, which will hopefully then approve the more formalities of going into the OBC around flexibility of capital costs. Because as we've never been given a formal number yet, we've always felt that it was 1-to-1 ratio, which has now been loosened by our regulators. So in essence, what that means is that work will continue, and as an outline business case, you have to go back and look in more detail at the options that you previously had. And by doing that, you need to go out and engage with the public and have a conversation with the public again around some of those potential options. So it takes the strategic outline case and turns it into more of a business case around what will end up being the preferred option. But it will review previous options to a certain extent to make sure that anything that may have changed in the preceding period of time till that's completed has been taken into account. We still maintain the judicial review position, and we'll update on that afterwards. But what I'll do now is hand over to Juliet, who will provide you some more information around potential engagement that's taking place.
Okay, thanks, David. Can people hear me? Assume so. Okay. So yes, as part of the process that David outlined, we will be undertaking an engagement program with the trust. It's going to be an engagement program like no other that we've run before for obvious reasons, because what we can't do is get people in a room. What we can do is get people on a screen and do other things as well. But it is going to be different. And I think the other thing to say about the difference is that we're also making more of an effort. I think we've always tried to do this, but we're making more of an effort this time around to really draw in people who we haven't had conversations with before. So our fan at the trust and the trust team, and Heather in our team that I think you all know, have been working together to pull together contacts with community groups from BME groups, for example, and others, so that what we can do is, as well as drawing on the huge cohort of people who have worked really hard as volunteers over the last many years in giving us their feedback on proposals, because we're not going to stop talking to those people by any means, but it's just about broadening the range of people who we hope to get involved. So the first step in this is that we have actually issued, and if you haven't had this, then I'm sorry, it's almost certainly my fault, but last week the Trust and the CCG issued an update, because what we haven't done for a while now is actually given information to the public about kind of where we're up to. And of course, as David's been describing, we've all been consumed by managing the incident, managing the pandemic, the future of the facilities, the hospital facilities, is so important. That work has been going on, and we now need to make sure that we inform people about that and then we get their feedback. So we did send out an update to the public last week, and I will circulate that. And in that update, we are inviting members of the public, local people, to join what we're calling a reference group. And actually, we think that can be as many people as possible who want to join in. And that will mean they will be invited to these kind of meetings, that we will send them information, we'll get feedback from them. And then what we will do with that group is, for the more detailed work around a bit further down the line, some service redesign and so on, we will get sort of people to work on kind of particular topic groups or task groups. The other thing we're going to make sure we do, obviously, is we're going to carry on doing all the social media. People will continue to be able to write to us, as they have done in the last sort of couple of years or so, so that anybody who lives or works in West Hertfordshire can have their say. So the timetable is that we are update notification gave information to invite people to that reference group, and which will launch effectively next month. And we'll be engaging over the summer with a view to a shortlist. And again, as David was saying, build on the SOC shortlist. So this is not an entirely new process, and that will come to boards in October. So that's the timetable. There will be that process involvement will continue to continue beyond that, right the way through until we have an OBC the following year.
Okay,
Shall I mention the JR, David, or? Yeah. Shall I?
Yeah.
Yeah. Okay. So the judicial review claim continues. What we were expecting originally, and what we were told, was that actually there wouldn't be a date until next year. We now know that we have got a date. It's in the autumn, and it's the end of October, 28th and 29th of October. And that process just continues. Nothing that we're doing now impacts on that, and nor does the judicial review impact on the work that's going on now. The important thing with the judicial review is that there's no decisions are being made that are irreversible, and that was actually the condition of the stay, if you remember from last year. But the principle applies that defendants are expected not to do anything that would effectively render the claim pointless, and none of that is happening. So we just continue with the process. It's almost certain, if not completely certain, that the court hearing will be remote. So there won't be a court that we appear in or that we sit in, and we will be doing it remotely. And courts all over the land are doing that now, and that will still be the case at the end of October, we understand.
Okay, thank you, Juliet. Right, open to questions or clarification. Anybody want to actually ask anything? Kate, is that you putting your hand up? No. Okay. So I think that's very succinctly put, and I think we're really clear, and I know there's a lot of energy going on from your team and from the West Herts team, Juliet, to progress this, so thank you. I'm now going to move on to the annual report and accounts for 2019-20, which is for approval. Over to Elka, please.
I think, Katie, are you introducing before?
Yes.
Thank you.
Yes, I can do. So most of the board will be familiar that this is something we've done for the last few years, which has come to the board to give some assurance around the draft report that has so far been prepared and shared with them. And part of that assurance is the Audit Committee Annual Reports Board, which explains how the committee's opinion on the assurances around control, risk management, governance in support of the governance statement, and the annual report and accounts for 2019-20. We've also had a board effectiveness survey, which was mostly positive, and the few areas where some areas for improvement were identified will be picked up at the board development session very soon. So the board's been asked to do a few things, so I'll take you through them one at a time. So please note the draft submission, which has been circulated. It was circulated on the 27th of April. That was the submission that we'd made to NHS England in draft, and the board has had a month to consider and make comments on that. The board, as individuals, need to confirm that they're not aware of any other relevant audit information that the auditors should know about, and that's what that next statement says on the front sheet, and that you've taken all steps that you ought to have taken in order to make yourselves aware of those matters. So if the board could kindly just confirm, or in absence of any comments, we could take it that you do confirm, please. There is a considerable amount of assurance in the Audit Committee annual report, and it includes some really quite favourable audit reports that have come through in 2019-20, and the auditors themselves have commented on how much the organisation has improved in its performance on those. And finally, the board are being asked to delegate the authority to approve the final submission, which has now been delayed until June this year due to the COVID pandemic, and delegate that power to the Audit Committee, who will be meeting on the 16th of June, so that they can agree the final numbers, because the accounts are still in process and the auditors have not finished their job yet. They've been working remotely, and I think that was something you were going to say something about, Elke?
Yes, absolutely. So just to say that our draft accounts were submitted at the end of April, in line with the deadline. But as part of the COVID arrangements, the auditor's timetable has been extended by a month. And that was directed by NHS England, and that was recognising that the same auditors are used across organisations, including local authorities, and that to be able to manage reduced resource or differences in accessing information as a result of COVID needed to have an extended timetable for the audit. So the audit has been undertaken, and we will then complete that, present the final annual accounts, the audit annual accounts to the Audit Committee for final publication. Just to add around the assurance that the board can take from the internal audits that have taken place, as you said, Katie, there's a reasonable and substantial assurance. And although we had a short delay because all of our focus was on mobilising a response to COVID, we are now picking up any of the outstanding actions that we will be putting in place as a result of the findings from the individual audits. I think that's probably all I want to say. I'm assuming the rest of the report is read.
Okay. Any other points or comments? Paul, is there anything else you want to add?
Yes, just to endorse what colleagues have just said, really. I mean, I think it's been quite a good year overall in terms of the assurance stuff around internal audit. It's good that the external auditors have found workarounds. I know in other organisations I work with, they're finding it more difficult, where they've got to have to do physical things like stock takes and things. So it is good that they have managed to work out how to do the stuff remotely. The audit profession is stretched out anyway for those that support CCGs and the public sector and local government, because there's not many bodies in it. So if they make it to the June 16th timing and get it done, that will be good. But I think this is the point really where board members just need to reflect individually on whether there's anything else that they are individually aware of. Hopefully there isn't, but they do have a duty to say so if they do.
Okay, thank you, Paul. Very clear. Any other comments? I mean, those comments are absolutely taken on board, I'm sure, by all members of the board. I think, Katie, we've sort of covered most of them. I think the only bit we haven't sort of formally done in the notes of recommendations is just the delegate the authority to approve the final submission to the Audit Committee on the 16th of June. So do I have approval for the whole package of confirmation, but particularly that last point. Yeah, David wants to say something. Oh, David's just saying yes. Okay, sorry. Okay, unless there's anything else, Katie, that we need to do from a statutory point of view. Yeah, we can move on.
Thank you.
Lovely.
Oh,
Okay.
Paul
Yeah,
wants to
somebody wants to say something. Yeah, Paul.
Yeah, just to remind colleagues that that Jane will have the dubious task of signing off the accounts, of course, rather than David as the accountable officer. So we'll need to make sure that she's A, briefed, and B, there on the 16th of June.
Okay, thank you very much. I'm sure that I think those arrangements are in place, aren't they?
Just ask,
sorry, Stuart. Yes.
Does Jane sign them off? And they refer to last year. So, you know.
We actually, Stuart, we took advice from Lucy Smith at NHS England about this because all the CCGs in a slightly strange position. They've advised that David should sign, but Jane should sign also. So he will sign to say that he was the accountable officer up to the 31st of May, and then we'll have Jane Halpin accountable officer from 1st of June because the accounts are not going in until June now.
That's the basic principle, Stuart, is that whoever's accountable officer at the time, they're accountable, and you inherit anything that's happened beforehand. One of the beauties of parliamentary accountability.
Understood. Thank you.
Okay, thank you everyone for that. Okay, unless there's any other comments, I'm going to move on. Okay, so item 10, which is just a review of the conflicts and how they were managed in the meeting. I don't have any particular observations. I don't know if others do, or if Katie, you wanted to say anything.
We didn't identify any conflicts for this meeting, Nicholas, so I don't think we need to review them.
Okay, and then item 11, which is the reflection on equality and diversity. I think, well, we have mentioned, haven't we, several points, particularly in the COVID update, the issues around PAME and also, you know, other issues pertinent to that. But I don't know if there's any other comments that we should make on that front. Getting anybody else wants to take a risks identified during the meeting.
So I just wanted to give the board the assurance that these governance processes that we have in place for the incident management and then going forward recovery and restoration absolutely are identifying and managing risks which are being monitored by the strategic team. And some of those will be reflected as key risks when they see the board assurance framework, the strategic risk framework in July. And there's a close process that we're monitoring on a weekly basis. Avni and myself, we've got the tactical delivery group, we've all got their own risk registers, we've got risks that are escalated. So some of the things that Diane mentioned, for example, around PPE or the care home support will be overseen, monitored, the risks will be viewed by IMT as well as the tactical group. So there is quite a sort of sound process based on our normal risk management process, but as another sort of program level risk management. I think the important thing is just to note that risk is the uncertainty about achievement of your objectives, and it's not always a negative thing. And everybody's mentioned quite a few opportunities, and I think a risk, if you like, is that we don't make as much of those opportunities as we can. So I think that's something that the board discussed at their last meeting, and that's something that we're very focused on, making sure that we build upon the silver linings that Diane mentioned. That's all I have to say, unless anybody wants to mention any other risks that were specifically identified, but I think they're all already identified as programme risks.
Okay, anybody else want to add anything to what Katie's very eloquently put? I think not. I just wanted, before we close the meeting, I just wanted to say a few words in public. So this will be David's last board meeting as interim accountable officer. And I want to play a special thanks, not only to David, but we'll go back to David in a moment, but also to Diane and all of the other senior management team and execs who have done an absolutely amazing job adapting not only to the change when Catherine stepped down at the end of the year, but also taking on the unique challenges of COVID I think the energy and dynamism has been quite remarkable, and the connection with our clinicians on the board as well. So I just really wanted to say, many thanks. Diane, the team, and the way that you've led IMT has been amazing. David, where do I start or where do I finish? I think that you have shown true leadership. You have been agile and adept at handling this situation and leading us where we needed to be led. And I'm tremendously looking forward not only to Jane Halpin taking over as our accountable officer, but David, to continuing to work with you in the MD role for our area, for our CCG. And I'm just delighted really at the hard work that everybody's put in. So thank you very much from all of us. Okay. And that really is the close of the meeting. I hope those of you that have dialed in or been watching us have gleaned some information from that. I think we are putting a recording, Trudy, that will be on the website at some stage later. Is that correct, Trudy?
We've certainly recorded the meeting, yes. So.
Yeah, fine. And clearly, if this is all work in progress, so we're very happy to take some comments which perhaps you can feed back to the CCG about ways that we can continue this style of meeting in the future. So thank you very much, everybody, and I'm now going to close the meeting. Thank you.